ABCB5 cells interthecal, 2.3 million ABCB5 cells intravenous, immediate effect. Always we found out that if you do with vitamin treatment, the same with antioxidants, at the same time you have a better homing of the cells, always in every time. So parallelly to the injection of the stem cell ID or whatever is the automolecular therapy. For 2 to 3 days after infusion, complaints from back and neck pains, like twist or sprain, dizziness, vertigo, and somnolence. Lasting effect after 12 days, gain urination control, which is a very important thing as well. After months, extensive tremor of the lower limbs when trying to move legs or body started stopped again after 10 years. So there's a transition phase of this. Second administration was in 2009 September, again 17.5 million cells, and intrathecal and the rest IV. Temperature rise to 38 for 2 days, gradually reassess after 2 days. Lasting effect. Now less fatigue, more steady, less ataxia, waiting for the third treatment in December. This was the time already done. And he is absolutely better now. Then the third treatment came on with 6.2 million intravenous and 12.4 intrathecal. General improvement of mobility, stronger, more steady, enduring management plan, outcome, less fatigue, more steady, and less ataxia as well. So this was a very interesting case as well. So what you can see here is that we have at the end of the day a situation where we can say it's a good approach, but it's not an approach where you can say 100% it works. And this is regarding to the cost of this treatment, something you have to discuss with the patient before, you know. You cannot promise anything, right, especially in these difficult diseases. There are many problems. It's not only the cells, as well as the problem of the application, the kind of application, how you know how many cells you need. This is, we are swimming in the dark, you know, in that case. We don't know if it's 17.5 or 20.5 million. So you're just going to learn. We're learning. So doing studies in this would be nice, but it's extremely expensive and it's not right now. Thank you very much.
Doktor David'e bir vakası geçirmiştik. Ondan sonra konuşmacılarımıza söyleyeceğiz. Dr. David Borowski has made his lecture in the morning, and now he will share us with a patient with the discussion.
Well, you've asked that interactive case discussion. I thought that's exactly what I'm going to do. Okay. Kind of it's a bit of a scenario which I spoke early on about the treatment of colorectal fistula. And I mean, it's patient 5 which I've had earlier in my lecture. I don't know what the range of experiences here in the audience. I've given you a little bit of background earlier. Now, I'm going back to this case, which is, I think, the one I think we've got the best pictures of. 38-year-old male, no comorbidity, he developed an ischiorectal abscess, which is not his picture. Different patient. It's an ischiorectal abscess at the age of 11. What would be the first treatment you would start off with? Any thoughts? Drainage? Drainage, yes. It's abscess, it needs draining. It's very old principle, obviously. Whether it's possible, you have to drainage. So, I mean, here you have the drainage of the abscess. Now, I mean, it's thought if it's the intersphincteric glands, basically, which are the culprit of this, it's really an infection in these glands, which are in the intersphincteric space, and that is where the infection is harbored. And it's draining to the outside. Yeah, so he did have a drainage at the time, came back with a, so sepsis control is the first thing. Yeah, then he came back later. For some reason, he did have a bit of learning difficulties, and he came back with years later with a persistent anterior fistula in ano. What do we do then? Well, we first of all make sure that is there any inflammatory bowel disease, Crohn's disease behind this. We didn't find evidence, no evidence of that. We then did an MRI, which showed the anterior tract. Somewhere here. This is one of the reasons why I didn't have the MRI in my talk earlier, because they are very, very difficult to interpret, and our radiologists try to find for this case where a good one. And here, this is like the white. This is where the collection is, or the tract is. Rather difficult to interpret and to show. Ignore the arrow, please. I don't know how that ended up there. But so it's anterior. Clinically, when we want to identify the anatomy, we try good old rule. We think the external orifice is corresponding to the internal orifice, roughly, and that was there. In this case, I've altered this picture slightly. You found that it was inserting a significant amount of the sphincter muscle, of both sphincter muscles, so therefore a simple laying open procedure was not possible, really. And you can see when you go back to the Seton picture, that it does insert a substantial amount of both sphincters there. Yeah, so just cutting through it basically would, almost certainly render the patient incontinent. Okay, good. What are the treatment options at this stage? We've drained it, we've put in a Seton to drain the abscess. What are the classical options, or when the past what would be considered? Colostomy? Well, I mean, a colostomy to cover something else is a possibility, but probably only as a protective measure for some other procedure locally to try to eradicate the fistula. So, the options are an advancement flap, where we go inside, close with an irregular advancement flap. I haven't got a picture of that. No, I haven't got that. No. Okay, sorry. Irregular advancement flap alone, probably the gold standard. The problem is that there are good theories about up to 87% healing rate from certain centers, but that is what they come up with. In a recent review article in the British Medical Journal, it said that probably advanced flap is about 30%. Generally, I would say that in general practice, 30 to 50%. 50% is probably what the healing rate is, which is by no means a good treatment or a successful treatment. The other options are we could leave the Seton for a long time and just drain it and leave it like that. The patient has got little problems, mobility from this. Then we go into the other options, which would be the filling in procedures, and at the moment we've got fibrin glue, which has got about 20% or so, 20 to 50% probably, depending on which studies we read, and we've got the option of a fistula plug, a collagen plug, just to close the tract, or possibly just leave it here for the Seton. So what we then decided after the workup is to get him into the study. I did our liposuction, placed him into the lithotomy position, found the internal opening, debrided around the tract. It was a fairly epithelialized tract by that point, so it's quite thick epithelium, so we cord out the tract of the epithelium. Did an advancement flap and then injected in and around, guided by the fistula probe, which is inserted through the external opening. Guided by the fistula probe, bulked up the tissues around the fistula and into the fistula to obliterate the tract well, literally, and also around the orifice, we also closed off, so trying to bulk around the external orifice to leave no dead spaces for this. Having closed the internal opening. And in this case, we achieved the, as we discussed earlier, the complete closure at 3 months with no incontinence and no recurrence at more than 1 year now. And on MRI, again, these were the attempts of our radiologists to cut the slices properly. You've got here the white speck, which is here it's not the same plane. That's the problem here. Really problems to get the same plane. And there was the first one in the pictures there. Because I think we didn't take too much care. That's why I didn't bring the. But on MRI, there was no further fistula he doesn't show me there. And clinically, he's very justified to do so. Okay. Any more questions? This was just made up that we're trying to get some kind of more detailed history.
I'm really interested in Dr. Francis' presentation about the mesenchymal stem cells. I personally work with them as well, but I have some doubts actually. As I understood right, you mentioned about injecting them into the arteries or veins for into the arteries, coronary arteries for myocardial regeneration, and into the femoral artery when in case of a ischemic leg, right? Well, have you measured the, when injecting them into the coronary arteries, have you measured the cardiac enzymes, creatinine kinase, MB, and troponin levels? And for the leg, have you measured the creatinine kinase levels?
Well, this is all done before.
Yes.
This is the injection has been in the coronaries, has been done by cardiologists. The patient was in cardiology. There we were the only things what we did, we supplied them with the cells, with the stem cells. So that's all done there. And I can assure you that it was done very properly as well.
Yeah,
There are protocols as well. I don't have them here because on this computer, but I can provide you with this. It's very interesting.
I personally made some experiments with them as well. But I have some. I know some publications from Lancet that they did injections into the coronary arteries of dogs, and they say the troponin levels are increased, which means there is myocardial ischemia as well. What my experiments was I measured the size of the mesenchymal stem cells, and then I injected them into the veins and followed them under the intravital microscopy, and they were huge. I mean, they were big cells ranging between, the majority of the population ranged between 16 to 55 micrometers. Although there were some cells below 10 micrometers and above 90 micrometers. They blocked the veins, they didn't penetrate, I mean, they blocked the arteries. Then I kept on, I injected them into the inferior vena cava. I mean, these are the animal experiments, and they were stuck in the lungs. So, I have really doubts about the mesenchymal stem cells. Although there are some other experiments saying the opposite, what I found, my findings were like this.
Very interesting what you found. The thing is, in this case, they injected them into the myocardium, directly to get the myocardium grow. And about the endothelial growth, again, the new vascularization, I'm not so sure how it works at the end of the day. If you get really a good vascularization or not. This is more in animal studies, done. And but probably you have your own experience in this, and I would be very interested to share with you your experience.
Well, I can send you the videos of intravital
very good.
microscopy.
Thank you.
And the thing is, in the long run, although you inject mesenchymal stem cells directly into the myocardium or the leg, there is no benefit I mean, the ejection fraction doesn't increase.
This is not completely right what you're saying, because the results of the study showed exactly that the ejection fraction increased.
In the early period, I agree with you. But in the long run, after 3 years, the ejection
That
fraction...
might be, yeah. That might be. That's the question. There we are at a point which is, I think, very interesting. We can share this. What happens? What is the destiny of cells after many years? You know, what is the destiny of fat cells, adipose-derived stem cells, or the destiny of hematopoietic cells? But it's very interesting to discuss this. We are not as far as we can say. This is really we know. You know.
Another thing, you showed some examples of injecting cells into the pancreatic artery or intravenous injection for Parkinson patients. Do you have any biopsy studies? I mean, do these cells, I mean, I'm sure they go there. Do they stay there? Do they pass the endothelium? I mean, do they penetrate the endothelium? Do they stay there? Do they differentiate? So, I don't know.
You saw the clinical results were not bad, you know. So you can probably say from the clinical results, but on the other hand, especially in diabetes type 1 was what I told you, autoimmunity destroys as well these cells, you know, partly. What is very interesting is, and what I want to show is these ABCD5 cells, they are pluripotent cells, so they're like embryonic stem cells. So they have a big power in this, but at the end of the day, you're completely right. If you work with autoimmune diseases, you have always one big issue, and is how long will the cell survive, and will the cell really home for long term in the organ, you know? That's very important.
And you don't have a control group, right?
No, these are all case studies.
Okay.
There's no one control.
May I have a question? Maybe. No, it's okay. To whom it may concern. Do you know, is there any publication reporting the coincidental healing of the pathology other than main pathology that for that the stem cells were given? Let me explain in this way. For example, the person has a diabetic foot, and you give a stem cells into arterial just to get rid of the wounds. And could be a case, for example, let him has a retinopathy, diabetic retinopathy or glomerulopathy. Do you expect healing in the other pathologies, for example, coincidentally at the same time, because you are giving stem cells the circulation, and stem cells theoretically are expected to go to other place other than wounds and homing them and maybe give a chance healing to organ, for example, retinopathy, glomerulopathy at the same time. Do you expect this kind of results?
You are asking me, right?
All the people.
There are a lot of unanswered questions actually. The thing is, stem cells are already circulating in the body, right? So they are in the blood.
Not so big amount.
Yeah, this is true, but they are circulating. So what we expect is the circulating stem cells should go to the, let's say, in a diabetic patient to the retinopathy region or in a nephropathy region and regenerate this tissue there. But it doesn't happen like this, right?
Because
so,
it is not as far as I know, the peripheral blood, please correct me if I'm wrong, there's not so much stem cells. That's why we are giving stem cells in the arterial. We are loading stem cells to the body. The body cannot create such a huge amount of stem cells as far as I know at the same time.
Okay, the experiment started like this. How about injecting GCSF? When you inject GCSF, the directly this drug stimulates the stem cells from the bone marrow. So bone marrow stem cells in circulating blood amount increases. So they should go.
Just regular plastic surgeon, maybe experts can answer this.
The other thing is blood is full of stem cells. For example, mononuclear stem cells, mononuclear cells. They have stem cells, and they should go and they should regenerate the damaged tissues. But it's like this.
My concern with bone marrow stem cells is very clear. Bone marrow stem cells, you have a lot of cancer stem cells in. You don't know what happens actually when you use them. So I don't use actually that. We had that in the first time, but I don't think it's a good idea. So this special group we are now focusing on with the ABCB5 cells, you know, that is not the solution, you know, like the solution, the fountain of youth for us, you know. But it's a way to see, and the company is just has founded a research company to find out, do more research on this, because, you know, right, what we have is case observations, studies, you know, more.
I mean, I'm not against these mesenchymal stem cells, but what the evidence shows is their diameters are larger than the venules or arterioles in the body, for example, the eye or the lungs, and they will be trapped somewhere. So I really have doubts. Thank you.
If I may, I'd like to actually answer one of the previous questions. Before I do, I should have a conflict of interest statement, which is that I am an employee of a company, Cytori, that manufactures equipment for the isolation of cells. So you might want to take that into consideration. If I could come back to this gentleman here about the cardiac cells. I don't know about bone marrow cells particularly, but cells, stromal vascular fraction isolated using our equipment from adipose tissue has been used in 2 randomized controlled cardiac studies. One was direct infusion to the coronary 12 hours post-MI, and the second was an intracardiac injection using a Nova catheter system for cardiac ischemia. Both are small studies, proof of concept. The MI study was about 14 patients. What was seen was in the treated group, there was a reduction in infarct size to below 18% and a 3.5-fold increase in perfusion, as opposed to the control group. In the ischemia study, the VO2 max was the major measure that we're looking at, and the VO2 max in the treated group stabilized and in the control group continued to decline towards the transplant line.
So you injected adipose tissue-derived mesenchymal stem cells?
The cells were not separated out. What we separate is the entire stromal vascular fraction. It's a minimal manipulation procedure. There's no culture, there's no expansion. We use, in our cardiac procedures, we use an additional enzyme to remove clumping. So there's a blended protease creatinase first, and then an additional enzyme simply to get the clumps out, and filters are used in the catheters.
And any measurements about troponin levels or CK-MB levels from the peripheral blood?
I've been sitting here trying to think if that was done, and I honestly don't remember. I don't recall. It wasn't one of the endpoints of the study. To come back to your second question, and here I'm going to go on various ends of one, but there have been instances where you've seen improvements that would not have been expected. One that stands out in my mind is a 43-year-old lady who received very bad burns as a child. She had burn scar revision to her arm, and they were expecting an improved take of the graft, which they got, but they also got the return of sensation in the entire regrafted area, which they had not expected. So there was some evidence there of some degree of nerve regeneration. So I think there is promising areas for investigation there, but I'm not aware of anything definitive that shows unexpected results.
John, I don't know whether you want to take a bit of reference on this. It's the Apollo data
To be honest, I think I've really said everything I need to say about it, but I'll be happy to provide the gentleman with papers later on if he wants.
Okay.
Şimdi Doktor Semih Bey bizlere kendi yaptığı vakalardan birkaç örneği tartışmamıza katacak. Onu da dinledikten sonra olmazsa küçük bir tartışmayla toplantımızı sonlandıracağız.
Dear colleagues, it's an honor for myself to be here with you, and it was a very kind invitation from organizing committee. And I would like to share my regenerative surgery experience for 4 years. And it will be a short presentation, actually, just to make things comprehensive. And fat tissue, which I call as fibroadipose tissue, is the best source for stem cells, or let's say multipotent stem cells. And fat grafting, which was defined by Sidney Coleman, is, I think, the workhorse of expanding regenerative surgery. And let's see what I have done, and I have no financial interest to disclose. And regenerative surgery has promising solutions for difficult to treat problems, because we are trying to enhance internal healing mechanisms of our body, and we are doing this via stem cells, multipotent adult stem cells, and growth factors, which are now available commercially also, which began, and bioengineered scaffolds. So we can produce bone, we can produce cartilage, and we can produce some other types of tissues. And I just want to share some case examples. And this gentleman, who is 67 years old male patient, having 20 years of diabetes mellitus type 2, presented as a life-threatening soft tissue infection and you see widespread tissue necrosis caused by a very violent microorganism, MRSA, methicillin-resistant Staphylococcus aureus. And after this presentation, he immediately transferred to ICU because of this life-threatening condition. And tangential debridement of the necrotic tissues every other day, composed with wet to dry dressings twice daily, and epidermal growth factor produced by recombinant DNA technology, injections 3 times weekly, resulted this condition in 2 weeks, which is a very rapid improvement in wound and also in general condition of the patient. And rapid granulation tissue formation also provided limb salvage. Amputation has been avoided. This patient discharged from ICU to inpatient clinic, and now we are waiting to skin graft this patient, and he's now also self-ambulating. Another different case example, which is a post-traumatic fascial deformity. This young guy, 30 years of age, male patient, and he suffered a gunshot wound 10 years ago, and he had a composite tissue defect. He lost his right eye, and he needed multiple surgery to have the space. And his main complaint was this area, fragile skin over temple and right malar area, and this was because this was caused by blast effect of the bullet exit. And he was complaining about itching and scab formation in this area, and there was a apparent color mismatch. You can see the red area and his color, the color of his normal skin. And after the structural fat grafting, this is passed up 2 years, picture of the patient. There's full color match and no itching. There's pliable and durable skin texture.